I kick off now? So I'm delighted to welcome Dr. Patricia Sheehan here today to share her presentation with us in this webinar. So Patricia is a lecturer and she's also the work placement coordinator in the Department of Sport and Exercise Science down in SETU in Waterford. Now I'm going to have to look at my sheet, Patricia, to make sure I get your PhD title right here, but it was back in 2019. Patricia had been doing a huge amount of research in this area and now continues to this day, but she completed her research entitled An Exercise Intervention for Cancer Fatigue. And she's presented all this work at national, international conferences, and it's also been transferred into practice. And that's the beauty of Patricia's presentation today. She'll be bringing her research to life and showing how it actually has had impact and has been used today. So we're delighted to have you here, Patricia. And if anyone has any questions, you can pop them into the chat, and at the end we will have time for questions. The webinar will be recorded as well, that we will upload it to the website afterwards. But I'll leave it over to you, Patricia, and thank you very much.
Thank you, and congratulations to you guys as well for launching this amazing association. It's a great platform to be able to come together and share and disseminate all our research in this space. So just a little bit, I suppose, about what we're going to look at today. Going to look a little bit about myself and tell you who I am, and that whole area as well, that it's something I really feel that is important, that whole the ethical imperative about translating research findings into routine practice. I'm going to give you a quick overview of my own PhD, the theoretical frameworks and the strategies that I used and put into place. And again, looking at the research, okay, we needed to get some results. We needed to see what's this going to work. But again, how I actually translated it into practice, and looking at some of the frameworks and the theories and all of that I used then. And I suppose from what I learned and the information that I gained then about, putting more research together and trying to elaborate and scale up, because I suppose the big thing for me is that I'm making sure, and I really want to ensure that I'm having an impact on the cancer patient themselves. So it's about translating it into practice. And I suppose I myself would have a call for action. So yes, as you said, I have a PhD in that whole area of what's kind of a buzzword at the moment is exercise oncology. And I've created a great team of friends in this area through ACSM and the special interest group there. And I'm really happy to announce that I'm also part of the ASHCR team, who's made up of myself, Dr. Brona Keogh of SETU Waterford, Dr. Mairead Cantwell of TUS Shannon, Professor Michael Harrison at SETU Waterford, and Professor Niall Moyna of DCU. And we are an exercise and cancer research consortium. So I suppose the big thing for me is why the delay in translation, and do we think that this is a little bit ethically and technically wrong as well? And translation of research findings into practice, it's actually perhaps one of the most salient current issues in cancer care. So I started to compile my argument about this whole delay in translation, and started to question, is it ethically and technically a little bit wrong that it's not being put into practice? Because we have to think about the patient here. And your argument, as my argument would be that timely translation ensures that, I suppose, that the cancer patient benefits from it. And what's the impact of delaying it? Well, your potential health improvements and health outcomes and quality of life are delayed also. I really feel that we have a duty of care to the participants of our research and disseminating our findings so that they can positively impact the lives of cancer patients. And again, the flip side of this is withholding the information. I think it undermines the ethical foundation of our research. There is research integrity to take into place as well. So failure to translate these findings, there's a gap between research and practice, and then that's raising the question as well about research integrity of the research process, and the gap itself then hinders the advancement of cancer care. There's an argument about health and quality. There's the other argument about professional accountability, resource optimization, and there's lots of arguments to be had here. And I'm going to not go into too much in detail. I have them up for you. You will have the slides. I'm just conscious of the time that we have. So just to give you a little bit of an overview about the research and the PhD that I undertook back in 2014, straight out of my degree, and that was an exercise intervention for cancer fatigue. We know that more and more people are living with and beyond cancer. We know that they have many unmet needs. They're struggling with the consequences of treatment. And we also know that cancer-related fatigue is actually one of the most debilitating side effects of cancer and its treatment, and persists for years. I was amazed with how many years people were post-treatment still experiencing this. And actually, it's an estimated 1/3 report clinically relevant cancer-related fatigue for up to 6 years post-treatment. It has been described in the literature as multidimensional. So there's lots of, it can be physical, it could be cognitive, it could be emotional. Some people can have all types. We have to remember that anyone who's gone through cancer is an individual as well. Their cancer is different, their side effects are different, their treatment has been different. It's a side effect that, lasts for years. And if we think about, if we are tired and we have no cancer, we usually find that our tiredness is alleviated by sleep. That's not the case in cancer-related fatigue. And it's also an invisible side effect. So just even from being with my own groups, it's almost like a guilt that takes over. My cancer is gone. How am I feeling like this? And it is invisible, so they don't even go and get this diagnosed. So again, the prevalence may also be underestimated. So Tricia then started researching and finding out that, oh my God, there could be something here with exercise. And sure, let's try and get all these poor people exercising. And we see all the research that's there and the benefits around exercise. However, even after the person has gone through the cancer diagnosis and come out the other side, at least 1/3 of individuals are actually, they reduce their physical activity levels, and it's estimated about 20 to 30% of cancer patients after treatment that they actually don't meet the physical activity guidelines. But behaviors such as diet and smoking improve, whereas exercise decline. So I want you to keep that in the back of your head as we go forward, because this is what I had to do. And I had to think to myself, why is that the case? So this leads into my study, and there was 3 studies that took place. So I needed to find out and compare, let's devise the exercise intervention. But then I started to see that an awful lot of the research that's out there already in this area of exercise and cancer, the primary outcome wasn't actually cancer-related fatigue. So therefore, a lot of these people didn't necessarily have cancer-related fatigue from the onset. But then I also wondered, okay, if I was to join an exercise group and I was to report positive impact on psychological and physical benefits, is it the exercise, or is it the fact that I'm with a group of people who are all in the same boat as me and having that group feeling? Is that what's causing the improvement? So what we did was we compared a 10-week exercise intervention with another intervention, which was health education. So the exercisers versus the health education group, but they all received the same, they had me for both groups. They had that same investigator attention. They had the group, everything. It was all the same, except for one group had exercise. And we had significant improvements in fatigue with the exercise group and the health education group. But we have to remember that we targeted cancer-related fatigue, but there was a huge improvement in the cancer-related fatigue, and the magnitude of change lay in the exercise group. And when I show you those results, but we also had pretty much significant improvements in cognitive function, quality of life, insomnia, fear of exercise in the exercise group, and this didn't happen in the education group. So then I needed to say, okay, we have found the effect. Okay, so we'll use the word effect over efficacy. So we have the effect, and what I needed to then find out, okay, but like, is what I found scientifically also what the participants themselves are saying and how they are feeling? So I noticed that, like, cancer patients don't necessarily always have their voices heard. So we looked at this in a qualitative manner, and we looked at their perceptions and their experiences of cancer-related fatigue, how it was managed as well, and their experiences of that 10-week program. We had all of these. We found that the qualitative data matched what we found as well in the effect study. And then I needed to translate this into practice. So what happens when we remove it from that strict research environment and we bring it out and try and reach the people that need it in the real world? So you'll see here the key findings that I'm on about. Now, when you see an increase in the score, that's not an increase in fatigue, that's actually an increase in energy. All right, so increase in energy levels. So you'll see that the magnitude of change lay in the exercise group, and they maintained that as well for 26 weeks testing as well. So the 10 weeks and then 16 weeks after that, they maintained their improvements also. So you'll see that, yes, we had change in the health ed, but we had all of these stars represent significant changes. And again, that was backed up with our qualitative data. So some of our participants noting that they're now healthier than they were before, back to work, sleeping better. Now they have a genuine tiredness, an improvement in their energy and their sleeping patterns. They loved the fact now that they were meeting up with people in the same boat, and this in turn was having an impact as well on their psychological outcomes. You haven't only saved me, you've given a family back their mother and their wife and their sister and friends back. I'm heading off to a birthday party tonight with a former colleagues. I would not have been able to do that a year ago. I would have used some excuse as I'm not up to it. Now that to me is having an impact. When I can see that we can potentially give somebody back their role as a mother, as a sister, and get them back to work, that's what it's about. Okay. So then I started to identify with all of this research that it was actually a behavior that I was changing. I needed people to exercise. So again, using that behavior change wheel, looking at the framework that was developed by Michi et al., and then looking at the key components of this behavior wheel, which are things like their capability, opportunity, motivation, and again, connecting those to the policy as well. So connecting the interventions to the broader policy categories. Okay, so who can facilitate or bring about this change so that so it would work for people as well. And all of my interventions were grounded in theory. Okay, and the reason for this is because, you know, it does work. So I really focused on the utilization of the social cognitive theory and various techniques, particularly focusing on self-efficacy. And when I mean self-efficacy, I mean, I couldn't believe the amount of people that had fear of exercise. I'm afraid to exercise. I don't know if I'm doing more harm than good. And I had to really focus on increasing their self-efficacy to exercise. So again, these barriers are there for the general population, but cancer survivors, they really face various different barriers. Like, I mean, ones that are focused on the disease, their side effects, I actually had one participant before and I met them in a waiting room. And then when I think back, imagine trying to sign a person up to an exercise intervention. And all those people want to hear is that the cancer is still not there, or I'm all clear. So I spoke to this gentleman and he said, nah, I'm allergic to exercise. And I thought to myself, allergic? I've never seen an allergy test done for exercise before, but recruited, and I can tell you, still exercising. So when we look at the main themes and sub-themes about the research that was there previously, again, I had to see, is it just me or is this just in general with cancer patients? So this was a 5-year following breast cancer diagnosis. So there was psychological, and you see that word? Fear, dislike of the gym. That resonated with me as well. Because the first thing we do is we try and get people exercising, maybe in the gym and all of that. And I'm like, not all people like going to the gym. The physical barriers, the cancer treatment itself, the fatigue, the weight gain, and then the environmental barriers. So again, going back to work, that was another one that, they don't have the time. So it's about getting the time of day right. What about, okay, you have an evening class, but what if that doesn't work for some people? And the whole world of work at the moment is up in the air as well. So just another little barrier for us all. So again, other research was saying that those barriers can be at an individual level or a situational level. So again, that change of appearance, feelings of fear, isolation, the time of the day, life roles, and people's social support. And that really is another thing that resonated for me, because I just think that we as a nation or as a culture, we nearly kill each other with kindness. So it's like the first thing we do when we hear about people who have come out of cancer and they now have cancer-related fatigue and they're feeling really tired is, we will prescribe rest. Go down, lie down. Oh, jeepers, don't be getting up. So are we actually doing more harm than good? And yes, there are times where you just can't exercise, okay? So here are some themes and sub-themes that I identified when participants discussed their experiences of physical activity and exercise following treatment. Fear of exacerbating cancer-related fatigue. The actual information that they receive from their healthcare providers, we must remember that the oncology team and the doctors, they are the real people. They know your cancer. But sometimes they don't have the knowledge or the experience or even studied exercise. So it's very hard to prescribe something that you haven't studied either. So therefore we have to think about or who fits into this puzzle as well. Fear of injury, so that word, fear. Fear. I was afraid then doing something because they were, you can read the quotes there. Okay, if I go doing that now, and then I'm going to end up in bed and all of this. And, we were told, like, don't put that. It was an awful lot is focusing on the don't. And that actually exacerbates the fear. So the fear of doing more harm than good. And again, some of the barriers that I identified as well were those physical barriers themselves, the psychological barriers, and the environmental barriers. And we have those backed up with some of the quotes that you can see there yourselves. I can't read them all because I have Sarah Jane's beautiful face over them, and I don't want to press too many buttons and lose what I'm actually looking at myself here as well. So I just tried to piece the pieces together for you. So this isn't a case of Trisha ran off with all these ideas. It's from the research that I started to understand the individual more as well. So research postulates that fear controls avoidance of a behavior. Self-efficacy theory then postulates a shared link between perceived fear or self-efficacy and that fear arousal. And then self-efficacy is a key determinant of health behavior change and is actually considered as a key construct in the social cognitive theory. So if lower perceived health competencies has been linked with lower levels of physical activity, we actually have that link in cancer patients. So again, I had to really look closely at that whole link about the patient's health competency and their self-efficacy. So I had to come up and devise all of these. It wasn't a case of, oh, let's meet up for once a week and let's go and do a class and that's it. Or let's do a lesson on cognitive behavior therapy with my health education group. Everything I did, I actually incorporated these theory techniques and come up with some strategies to reinforce it. My participants didn't know what I was at. I knew what I was at. So like with the exercise and the help group, feedback, monitoring their progress, seeing the huge thing was education. Educate, educate, educate. I say it to all my students now in strength and conditioning. I say it in group fitness. I say it in fitness and movement. You are the instructor. You are the educator, you are the motivator, you are the everything. And to develop that self-efficacy, you have to build that in. So setting goals specific to the individual and the reinforcement. And anybody who is on here that's maybe tuned in as a student in sport and exercise science, these are things you learn. But guess what? You have to apply them in the real world as well. I had to do techniques as well with motivation. So like the pedometers turned out to be great, tracking the progress, sign-in sheets, all of those. I'm not going to read through them all, but these are some of the key strategies I put in place for adherence, health competence, self-management, fear, and I really think that what worked best for people was the skill that they were learning, the skill of exercising correctly, which in turn didn't exacerbate anything. It actually helped to improve. And of course, our cup of tea after every session and having that time to chat, to share, and just learn from each other. So again, here's some key messages, I suppose, that whole embedded in theory, having the weekly support for everybody and having that holistic approach. So there was a variety of messages with our tip sheets, our worksheets, everything employed. I'm not going to go into too much detail about other theories, but there are other theories that I really zoned in on that you can take a look at in your own time as well. And I've highlighted in red then what I built in to try and tackle these theories as well. So then after all of that, I had to go and find, okay, this is amazing. I've heard what they've said. I owe it to my participants not to leave this research on the shelf, but to translate it into practice. We need to get this out there to have an impact on every cancer patient in every town, village. So I needed to look up then another what's called an active implementation framework. And this one was developed by Fixon. And, going through, well, what are the key components I need to look at? What are the stages of implementing this into the real world? Who can drive this for me? Who can I involve in the decision making to make this work? The continuous improvements I can potentially do. How will I apply this across all sectors? And then that whole flexibility or the fidelity. Okay, what Trish is doing in Waterford, how come it's not working, say, in the likes of Kilkenny? So having this almost like a best practice that we can give to people to set this up. Active implementation frameworks looks crazy. And when I started to delve into this, I was like, wow, this is. But at the end of the day, it is a little bit logical. So it's the who, the when, the what, the how. And when you look at the who is, okay, who's going to take the responsibility for guiding this process? And when we look at the how, well, who are the drivers when it comes to actively implementing this? And how am I going to create a more welcoming environment and a setting to solve my issue of getting this into practice in the real world? And then what steps am I going to lead to successful implementation? I don't just want to implement this. I want this to be successful. So again, there's another formula that I found, and it was actually a formula for success. And I was like, oh my God, this is actually so cool. How can I put this formula into my research? And again, what this framework looked at, or the success formula, it looked at, okay, if we have effective intervention, yeah, I have one, did my effect study, and I now know that that worked, I have that. And then we look at effective implementation methods. Hang on, yeah, had that, good quality, supportive, yeah, we can do that. Accountable and supportive systems, yes, we have that. And we multiply that by enabling context, which is our national policy, national monitoring, our surveillance. We can have a significant impact or a significant outcome. And that to me is having exercise rehab programs embedded in cancer care across the board in Ireland to improve quality of life and physical function of our patients and survivors. But let's not just look at one thing. Let's multiply that by that by that, because this will generate a greater impact compared to just adding up effects one at a time. So what did Tricia do? She linked it all in. She linked it all in with my framework, my active implementation framework, and my key for success formula. And what I did then was my study focused on the process and the resources. So identified the key people, the key stakeholders, identifying the barriers. Okay, there's still barriers. I still don't have the XWell medical or the XWell program in SETU Arena that is accessible to all. Why? Because we don't have a public transportation out to SETU Arena. So there is still a barrier to scaling this up. So it doesn't just happen. It takes time, but we'll get there. I'm always on about the bus and addressing those potential barriers for implementation as well. So here are some key findings that I've got. So we've got from the program structure, we've got the group, cancer specific. These are all the things that from a program point of view, your implementation team, it has to involve a multidisciplinary team. You have to have a leader to coordinate this. You have to have your local champions. Love that word. I want to be one. And the structure program, including education. You have to educate, you have to instruct, you have to motivate. You're not going to have that without having the knowledge. So making sure that you have a professional and a specialist involved. But guess what? We need funding. Okay, there's a huge need for funding here. Here are all the intervention characteristics that worked, and then some of the barriers when I spoke to the healthcare professionals themselves. Okay, their appointment time. What if it's only 12 minutes? How can they get to talk about exercise in that time as well? Methods for contacting the healthcare professionals, key individuals to target. Who are the people that I need to target so that the patient finds out about these? And then we need to build the trust between us as exercise practitioners and the healthcare professionals. And we can potentially do that. And it is happening. We're starting to see that now. And then that whole ease of referral. People hate filling out forms, and doctors most certainly, and healthcare professionals, they're so crazy in their work. Trying to fill out a form is only adding to that. So how do we refer with ease? And there's lots of other key findings that we found. So how do I ensure like that? How can I make this program that is working so well here work everywhere? Okay. And I suppose the level of change that's needed, we need buy-in. We need buy-in from the people in power. We have a national strategy in place for cancer. We need to use that, and we need to apply to the powers that be to get this put in place. So again, about enabling context then as well, and creating that safe environment. So from all of that, Tricia devised a model of best practice, and these are the key things. So specificity was key. It has to be at all stages of cancer. So why can't I make my patient fit for surgery or fit for their treatment? Involve that enabled environment, the social and educational elements. Yes, group-based, but was that because I spoke to people who came from a really good group-based? And we have to remember the more I look at it, is it's not a one-stop shop either. Okay, because remember, one of those barriers we did identify was that some people don't like going to the gym. Okay. And again, implementation should include local champions. It should include all our key stakeholders, and engage the wider community. Let's collaborate. Let's all come together. It shouldn't be the exercise professional says this and the physiotherapist is saying this. Look, at the end of the day, we all want to do things for the health of our cancer patients. We're there for the good of them. So that's why we should come together to make it happen. I suppose the big thing, if you're going to be wanting to receive funding, the likes of a cost-effective studies are also needed as well. So from all of that, earlier research is kind of what is bringing to me where I'm going to with this research now and leading it to current projects. So we have the Data Dance project on the go here in Waterford, up the data. That was funded by the National Cancer Care Programme, and it's a partnership between ourselves and the Solace Cancer Support Centre here in Waterford. And we're actually targeting, because like that, they themselves identified as well that maybe younger women under the age of 45, that they don't sometimes like going to the gym, and sometimes that type of workouts doesn't work for them. But what we did was devise and develop a supportive dance intervention, so fostering physical activity in a friendly, safe and enjoyable environment. Its key focus, again, of course, is getting people moving who, if you've been through cancer, and promoting physical activity, engagement with peers through dance, and evaluating the impact on self-efficacy for reducing that fear of physical activity. We've done all the data collection, so we're in write-up stage of that. And the ASHCR team, so myself and the ASHCR team, we've just, it's in, I suppose, it's to be published shortly, so please watch this space. And what that was identifying existing cancer-related physical activity services that are out there and exploring the gaps in provision, and then the differences between research-led and then the existing community-based. You can kind of see where we're going here, and Trisha's head is like, yes. And then proposing ways to expand our services for cancer survivors, addressing the barriers, making them more, I suppose, well received by the cancer patient, and proposing some national recommendations. But I suppose the key thing from that was, and that's, I really started to identify that it isn't a case that it's a one-stop shop, which led on to my SETU PhD scholarship project called REACH. I love that word, because at the end of the day, that's all we want to do is reach. So it's resources for exercise and active living in cancer survivors. So what we're hoping to do is address the underutilization of, say, the programs maybe that are there now, identify the barriers and explore how we can overcome those, but also develop a patient-centered bank or menu, or, develop the resources so that we can have those resources there for people. So it's like almost like a menu of choices, so you no longer have the barrier of, I'm not going to go to the gym, that there is like a menu of options there. So we're going to follow those Medical Research Council guidelines for developing and evaluating these complex interventions, because they are complex. We'll conduct then an evidence synthesis, we'll engage with key stakeholders, and then develop digital-based, paper-based, at home, in real life, and try and develop as many resources as we can as possible as well. So that was kindly sponsored then by SETU PhD scholarships as well. So at the end of the day, what do I want? I want project impact. I want to bridge the gap. So provide evidence based on resources, or evidence-based resources to the healthcare professionals, and bridge that gap between these guidelines and practical implementation, and aim to increase physical activity rates among our cancer patients, and at the end of the day, enhance their care. So we have the potential to significantly enhance cancer care in Ireland, ensuring that every cancer survivor or patient has access to support for a healthy and active life, either post-cancer I'm looking at here, but it can be across the board. So here's my call of action. And this little picture is representing all of that research on the shelf. And here I am reaching my hand out to make it out there and give it out to the powers that be. So knowing is not enough. We must apply. Willing is not enough. We must do. And why this matters to me is we have to reach everybody, ensure that the research reaches everybody who needs it, breaking it down. Break down the barriers and make it more accessible, because at the end of the day, we can have a positive impact by translating our findings into practical solutions, positively impacting the lives and communities of people. And again, we have a duty. Leaving research results on a shelf, it's not just a missed opportunity, but I think, you know, those seeking hope and healing deserve to have that as well. So let's turn our knowledge into practice. Thank you for being part of this journey to bridge the theory and practice, turning research into meaningful strides for a well-being for all. I have so many people that I have to thank for supporting me all of the way through this. Without research participants, I wouldn't be able to continue with my research. Without the research support centres, again nationwide, we wouldn't be able to continue with our research. Southeast Technological University, Waterford, and now joining forces with our other campuses, because we have supervisors on our new SETU PhD scholarship program there as well. Again, gratitude to you guys for the support of funding this. To my ASHCAR team, thank you for the dedication and enthusiasm. My colleagues and workers, the ACSM SIG group, you guys, the webinar participants, because now you've heard it, you have to spread the word as well. And of course, thank you to the Irish Sport and Exercise Science Association for inviting me. And a heartfelt thanks to all of the cancer support centres out there, that we can actually reach the people that we want. And again, our healthcare professionals, because you guys are part of the picture and part of the jigsaw that we need to work together with to make it happen. Thank you.
Patricia, thank you so much.
I'm going to just stop sharing here now, because there we
Perfect.
go.
Thank you so much. I forgot how your passion is so infectious. I feel inspired that we're all going to go now and take this information on board. If anyone has any questions, you might pop it into the Q&A section, and we can see the questions come up and we can feed them in. So I actually forgot to say that Patricia's really our first webinar. The first one back before Christmas was myself, Sarah Jane Cullen as vice chair, Tom Cummins as chair, and Ed Collin as the secretary of ESA. We would have been speaking about, you know, the establishment and what's going on with ISESA. So Patricia has been so kind to be our first formal webinar.
No pressure.
No, but you set the standard high, which is fantastic. So we really appreciate it. Does anyone have any questions that they'd like to feed in? Patricia, I might just come in with one there.
Yeah.
Sorry, I'm used to seeing you every day. I'm going back to Trisha. Patricia's too formal here.
That's fine. Absolutely. Absolutely.
How does Ireland fare up compared to their international partners in terms of implementing the research?
In this space, could, you know, that kind of report could do better when you get a when we get a school report home. We can do better. I think, I mean, the likes of Australia, who have it embedded within the cancer care continuum, that's what we're striving for. So we are behind in this area compared to others. I mean, you know, but we're getting there. We're getting there. And that's thanks to the funding that we're receiving, that I'm now seeing, because at the beginning, I suppose, when I was doing my research, I had to then try and sell it as well to the powers that be and get buy-in from, and that takes time. If you look at the research in exercise oncology 10 years ago and how far we've come now, if you were to look at it, we have come a long way, but we could do better. I think that's because I get a little frustrated because I see these barriers to implementation and I have the solutions. I say that to all my students, you bring the solutions, not the problems. I have the solutions. I just need the powers that be to act on that as well. So could do better, but I think we're in a pretty okay place, and that's down to the funding that we receive to actually undertake these projects.
Yeah, it's interesting because, you know, sometimes with the research, it's research to sit in a shelf, but you really are, you know, it's exciting because what you're doing is actually informing practice policy, and hopefully people are taking on board to change people's lives and support them.
And I think being part of that special interest group and the ASHGAR team, that's been driven by people who are really passionate in this area, that is going to help, I suppose, Ireland as well, because we will eventually have multi-centre, multinational programs that can benefit people within our country, and we can learn from those who are really excelling in this area as well.
Yeah. Tricia, just talking about someone, say you came from a sport and exercise science related degree, and how did you even consider getting into a PhD like this, you know, in the area of oncology and exercise oncology?
Okay, well, big time, I suppose the whole thing is that all of our families have been affected by cancer at some stage. And I suppose I'm one of those people always wants to have an impact. I will probably be seen as almost like my dad, who is a community advocate. We're involved in every club, every committee, and I saw the impact that the Men's Shed had on men's lives. And you know, my dad would have started that, would have been one of the co-founders of the Men's Shed, and I did my research, my undergrad research in Men's Shed. But then I started to see that even though we had evidence, it was the huge gap for cancer patients. And like, if you had, when I started to look like, as well as the cancer care pathway, if you have a cardiac event, the chances are you get cardiac rehab, which involves exercise. If you have a cancer diagnosis, there is no cancer rehab. Okay, so again, now I understand it's a multitude of diseases and all of that, but I chose it because I wanted to have the opportunity to make a change and help at the end of the day.
Fantastic, and you certainly are doing that. Megan Cooney, thank you so much for your question. So, Tricia, is there anything you would do differently with your PhD now, looking back?
Oh my God, what a question to ask anyone who ever undertook a PhD.
A long list.
Yeah, I think that's a whole other webinar. But is there anything I would have done differently? Okay, the big thing is, if I could have had a randomized controlled trial, that would have been amazing. It's seen as the gold standard. However, when you want to translate it into practice, a randomized controlled trial is so strict in finding the effect. Translating that into practice could be more difficult. So yeah, I would love to have ran a randomized controlled trial as my first study. But when we stand and take a look back, while it's gold standard, it's quite a rigorous set or environment to be in as well. So would love to have done that, but guess what? That's a recruitment. I was trying to recruit people with documented cancer-related fatigue and sign them people up to an exercise or health education program as well. So that's what made it so unique as well, was the inclusion criteria.
Brilliant. I thought your qualitative piece was lovely, because sometimes we can get the numbers, but actually what do the participants, what are they feeling themselves, and have their voices heard is really important.
And have their voices heard, and that's what I wouldn't change. That's what I won't ever change, because if I can be the voice for them and be heard by the powers that be, I will stay being their voice. I owe that to my participants as well.
Nornie Flanagan, thank you so much for your question coming in. So I know muscle mass is a key determinant in cancer survivorship, but the ACSM guidelines and your work is non-specific in terms of resistance and endurance exercise. So do you think there's enough evidence there to support resistance exercise over the likes of endurance exercise if survivorship in cancer patients is still your main goal? Or what are your thoughts around that?
Okay, so the prescription for exercise is both. And there is quite a lot of research there for aerobic and strength. We have to remember as well that I would have done some strength work with my participants as well, because a lot of them lost strength or mobility in the area of maybe where they had a breast removed, or so strength is a part of the prescription. It's a part of, you could say, sometimes they take a tablet and it's the paracetamol for pain and the anti-inflammatory. Well, we do need the aerobic for cardiovascular endurance and to work there. But we also need to understand as well that a lot of these people will have lost muscle mass and lost strength as well, due to even becoming more sedentary, and that is a crucial element to the jigsaw as well. So the likes of Professor Kieran Fairman has a huge amount of research in this space as well. So I would certainly, if I were you, go and look at some of his research there as well.
Super. Thank you very much, Patricia. I don't see any more questions coming in, so we might leave it there. The recording of the webinar will be put up online, and Patricia's very kindly agreed to share her slides with us. So really appreciate you coming on, sharing your thoughts and your research and your practice with us today.
And again, my email is at the end there. If you want to reach out to me, I'd only be delighted to speak to you. If anybody out there as well would ever want to collaborate in this space, or speak to me as a student who works or is in the area of sport and exercise science, because I look after students in work placement, certainly I'll have a chat there. And if there is any organizations out there who would like to host our students in placement, of course I'd like to chat to you as well.
Patricia, thank you so much.
Thank you.
Exercise Science kicked this webinar series off. Our next webinar, there's going to be one every month. So the next ISESA webinar is going to have a sports science focus. So Aidan O'Connell, who's head of performance from GAA, Cork GAA, has kindly agreed to be our next webinar presenter, and as one of the first sport and exercise science graduates in the country, going to share his experiences and learnings from over the years. So that's going to be on a date for the diary, the last Thursday of February, so the 29th, Thursday the 29th of February, and it's going to be at 12 noon. So we're going to try aim for the end of the last Thursday of the month at lunchtime to try and let people have a little date for their diaries. So mark that
I have another date for your diary, guys. So here in SETU Waterford, we're actually going to be hosting a careers event, or like a careers fair as part of Tutor Week. That's taking place on Tuesday, the 27th of February. So if there's any people who are, maybe wanting to become a student in this space, or getting securing a placement that might be within our department now in sport and exercise, nutrition and exercise, health, anything like that, it might be an opportunity to meet with them. And any host organizations that would like to come to that, this is your official invite as well. Might see you there, SJ.
Tricia, thanks for sharing that. And that's perfect. That's what ISESA is about, bring the community together. So thank you, and hopefully people will attend that. Right. Brilliant. Any questions, get in touch, info@isesa.ie, and keep following us on all the different social media platforms, Irish SESA, to see what's coming up. And thank you very much, Tricia.
Thank you.
See you all soon. Bye.
Bye.